We're going to turn now to a discussion of postpartum obsessive compulsive disorder, or OCD. Now, this isn't strictly a mood syndrome in the postpartum, but it has a lot of similarities to the three major mood syndromes that we've talked about: the blues, postpartum depression, and postpartum psychosis. So it's important to understand what it is and what it is not, to have real clinical insight and diagnostic clarity into what's going on with our patients in the postpartum. So OCD will typically present in the postpartum with intrusive thoughts and images that will often concern infant harm. The prevalence is unclear, possibly up to 9% in the postpartum, and remember that OCD in the general population is about 1 to 2%, so that's dramatically increased prevalence. We also know that when people have onset of OCD in pregnancy, it's often associated with contamination obsessions and cleaning and washing obsessions. For those who have onset in the postpartum, on the other hand, illness is often associated with intrusive thoughts of infant harm and avoidance and checking compulsions. The content of the intrusive thoughts can be violent, sexual, or religious in nature, and overt compulsions are less common than covert behaviors and situational avoidance. For example, we have to remember mental compulsions, not just physical behavioral compulsions. For example, somebody who is constantly seeking reassurance or calls 6 different doctors to get an opinion on a symptom that she thinks she is having, or obsessively Googles to try to find information about something, those may be compulsions that are trying to reassure her for the distress that she's experienced. One of the key things to understanding this, though, is to remember that these intrusive thoughts in OCD are ego-dystonic with preserved insight. So the question is, does this fit the symptoms of the case we gave of Mary's symptoms? Well, we heard a lot about Mary's mood symptoms, but remember we also heard some intriguing, vague comments about the fact that she's standing near windows for long periods of time. And we don't know what that's about and whether that could be associated with something like intrusive thoughts. We also heard that she has a lot of worries about her health and that of the baby. Could that be associated with intrusive thoughts? We need to ask more questions. When you're evaluating a patient for possible postpartum OCD, it's really important to ask directly about thoughts of harming the baby. Clinicians are often scared to do that because it seems like such a sensitive topic, but if you don't directly ask, women are not going to volunteer that information. When you ask, it's important to note that these thoughts are common and don't morally condemn the thoughts. Talk about it as something that commonly happens in the postpartum and ask the patient if she's experienced them. The way I often ask is to say, many women in the postpartum will experience sometimes scary thoughts, intrusive thoughts that they can't get out of their mind. Sometimes those thoughts might even be about harm coming to their child or themselves harming the child. Has that ever happened to you? And that way the patient knows this is something common and something that she can open up about. There are 3 kinds of thoughts of harm to the child that can happen in the postpartum. One is these intrusive thoughts that I've mentioned, where just thoughts about harm coming to the child. There can be actual thoughts of harming the child, but without any intent to do so. And there can also be thoughts of harm with intent. Now that's got to be distinguished from the intrusive thoughts of obsessive compulsive disorder. You also want to assess the woman for symptoms that would increase the likelihood of her acting on these thoughts. Does she have any psychotic symptoms? Does she have any suicidal thoughts? Does she have a poor social support and a chaotic life? So how do we tell the difference between obsessions or intrusive thoughts and what I'd call obsessive anxious thoughts? Remember that both are very common. And if they are true obsessions, they may be accompanied by compulsions, whereas anxious thoughts may be less specific than true obsessions, and the focus of them may change. What if this happens today? What if that happens tomorrow? Whereas if it's an obsession or an intrusive thought, that content is going to be fairly constant. Both kinds will increase anxiety and agitation, and it's important to remember that women will be very ashamed of these thoughts. They think that it's something that's never happened to anybody else. They don't want to reveal them because they're concerned that people may think they're not capable of taking care of their child. So how do we distinguish among all of these syndromes? Well, one thing to remember is that there's a high comorbidity of depression and obsessive compulsive disorder, as well as a high prevalence of obsessions in postpartum depression. So they're often intermingling and overlapping. But one thing that's really important is to make sure that we distinguish postpartum obsessive compulsive disorder from postpartum psychosis. The two can often present in very similar ways, but it's vital that we make that distinction. How do we do that? Well, obsessions are intrusive thoughts. Remember, they are unwanted and horrifying to patients, so they're ego-dystonic. Whereas the delusions of postpartum psychosis are fixed false beliefs that aren't ego-dystonic. They are not unwanted and horrifying to patients. The intrusive thoughts of obsessive-compulsive disorder can be sexual, religious, or violent. So can the delusions of postpartum psychosis, but in postpartum psychosis, the content is often bizarre or unusual, which isn't usually the case for obsessive-compulsive disorder. In OCD, the patient has no desire to act on these thoughts, is horrified by that concept, whereas in the delusions of postpartum psychosis, patients may want to act on these thoughts or may feel compelled to do so. In OCD, the thoughts cause considerable distress, and patients may avoid things or engage in compulsive behavior to ease that distress, whereas in postpartum psychosis, the thoughts may not cause significant distress. A good example of OCD would be a mother with an intrusive thought about molesting her child, which she has whenever she's changing diapers. This horrifies her, and she insists that her partner change all the diapers. Whereas in postpartum psychosis, a good example would be a mother who thinks her child has been cursed by the devil and she must throw him or her out the window. She feels compelled to do that, and it doesn't cause her significant distress because she knows it's what she has to do. So why do we distinguish all these syndromes? Why do we care if it's OCD versus postpartum depression? Why do we care if it's postpartum psychosis versus postpartum depression? The real answer is that treatment differs. For the baby blues, no treatment is needed. It resolves on its own within 2 weeks. It's not a psychiatric syndrome. For postpartum depression, we can treat as a major depressive episode. We can give SSRIs, and that's usually quite effective. We also have some new drugs for postpartum depression, and the data for those is specific to PPD. I'll talk about those a little later in the talk. For postpartum OCD, again, we use SSRIs often. They are likely required, and we have one form of psychotherapy, CBT, with exposure and response prevention, that can be very effective. But remember, for SSRIs and OCD, we want much higher doses than we do in postpartum depression. So it's important to understand which one we're dealing with. Finally, for postpartum psychosis, an antidepressant is usually one of the worst things you can give because many of these patients are presenting with mania or mixed symptoms. In fact, what we want is lithium. That's the gold standard treatment for postpartum psychosis, sometimes with or without an antipsychotic and benzodiazepine for immediate symptom relief, but lithium for long-term treatment and for prophylaxis for the next episode. Let's review a few key points here about postpartum OCD. Remember that it's much more common than was once thought, and it includes intrusive thoughts and behavioral responses to those thoughts that may decrease the distress of the thoughts. Behavioral responses may be typical physical symptoms, such as we think of for OCD at any time, like checking, but it also may include mental compulsions, such as seeking reassurance or looking things up over and over again on the internet. Intrusive thoughts about harming the infant are extremely common in postpartum OCD, but they actually do not indicate elevated risk of actually harming the child because the thoughts are horrifying to the patient, they're ego-dystonic, and the mother is not more likely to harm the child than somebody who isn't having those thoughts. But with that said, it's very important to make sure that what you're actually seeing is the intrusive thoughts of OCD and not the delusions of postpartum psychosis. Women with postpartum psychosis are at elevated risk of harming their children, so it's really important to make that distinction.